And this, is, we believe, is actually quite prominent when patients are diagnosed. So that in reality, the belief that you're diagnosed, you've lost 90% of the beta cells, I personally don't believe is true. I think what I'm seeing from data, and we need more, okay? I think we need more. But I think that many patients, not necessarily all, but many patients only have a marginal loss of beta cells at the time of diagnosis. Over time, this could become really severe. But during that time, there is a lot of dysfunction of beta cells that at the moment in clinical trials, we're not treating specifically. So that's why also what the concept of combinatorial therapies actually make a lot of sense. If we can, but it would help to have a little bit more of a better idea of what is this dysfunction at a molecular level and how can we target it. So, but here, what they show, these are patients that had diabetes for a very long time. If you look here, they go from 0 to 70 years. And you can see that they're now using assays to measure insulin. And actually, they don't measure insulin, they measure C-peptide, which is a byproduct of insulin. But it's the same. And so what they see here is that some patients are essentially not doing much. But actually, there is still a little bit. And here, there's a little bit more, a little bit more. Again, there's nothing that you say, I'm going to get cured of my diabetes or I can get off insulin. But there is a response. What's important is that, look, the majority of patients, when stimulated, they go from a certain level to higher, right? So there is a response. It's not flat, right? So that's very important. Now, but also I wanted you to look at this. That's why I put it in red. So these patients here have a peak stimulated insulin secretion that is meeting the threshold for inclusion in clinical trials when you're recently diagnosed. There are several of them. And if you look at the duration, is somewhere between 10 and 30 years or so, maybe even a little longer, I'm not sure for me, but pretty long, right? So what we don't know here is what the actual amount of insulin secretion rate is overall during the stimulation test. For a number of reasons, these colleagues that did this study, what they did is they stimulated the patient and they took a blood sample in 90 minutes. Okay? So number one, for some people the peak might be in 90 minutes, for some people it might be at 60, so maybe for some people they missed it. But also by taking a single measurement, you only have that measurement, you can actually calculate the whole amount during the period of time of the test. Okay? And this is what we measure when we try to evaluate whether a therapy, for example, is safe for diabetes. What is the total amount that you make during a period of time of the standardized test? It's really how much are you making, right? So it could be that these patients have a quite wide curve, and so there is a lot of insulin that is made, or they have a very narrow peak. In other words, yes, they can go at a higher level over a very short period of time, and overall the amount of insulin that is made is actually small. So we don't know how these compare to what we see near the time of onset. So these studies, they're going to get done, and then we will know. So my hope is that in some of these patients, this will not be as bad as we think it might be. I think it actually will be surprised. And ultimately, what I would like to see in the future is that we no longer say we're going to do a trial based on you have diabetes for less than 3 months or 1 year, but based on we assess your beta cell function, and based on that, you have enough that you could have a potential benefit on enrolling. And whether you have diabetes for 3 months or 10 years, it doesn't matter. But but these are things that happen all the time. What you have to consider too is that when we do a trial, we want to try to put ourselves in the situation where we have a higher probability of seeing an effect, to be sure. If we take too much of a risk and start to enrolling patients 10 years out now, without knowing this information, we might actually fail. But fail because there was not much to be said here, we didn't know, and we hope, and then we might discount a treatment that actually was quite important if we don't do things right. So unfortunately, many things have to be done in a stepwise fashion, but we want to get there. And we want to make sure, because my personal belief is that this is a lot more chronic than we ever thought it was, and there is potential for benefit way longer than 3 months and a few years down the line at least. So hopefully that will happen in the future.